you compare your answer. Okay. So you can gauge your understanding lah, ya. Right. Ya, apa dia? Oh, campus tak dengar kan?
Speaker.
Oh, speaker tak
Tak
dengar.
sedap.
Okay. Alright. Okay, jom. Akmal kata start boleh ke?
Boleh.
Jom, okay.
Okay, Assalamualaikum and very good morning everyone. So today our topic for SME is the compartment models and TIVA. So compartment model are mathematical equation used to predict plasma concentration of drug based on experimental observations. The predict plasma concentration is under a variety of conditions and pharmacodynamic effect. The model can be used as the compartment model. So the compartment model has one compartment model and multiple compartment model. For the one compartment model, is the simplest model, a single Western homogeneous compartment. If a single dose of drug is given, it's instantaneously dispersed evenly. Macam mana nak? Sorry macam mana nak? Okay. Dispersed evenly throughout this compartment. And elimination is an exponential fashion with a single rate constant for eliminations. So if we see this concentration time graph, the elimination is actually the exponential. So from the one compartment model, the mathematical equation to expect the concentration is in one compartment model is this equations. So where the CO is actually the concentration at the time 0, and the K is the rate constant for elimination, actually the fraction of volume distribution from the which drug is removed in unit time. And this volume is actually the clearance, where the clearance can get from the product of the rate constant and also volume distributions.
So pay attention to these parameters. Lepas tu tengok graf balik, kenapa dia tak touch the y-axis?
Oh,
Kenapa dia tak touch the y-axis? Soalan favorite survivor. Kenapa? Okay.
So theoretically, we can finish that.
We never finish tak yang mula-mula tu. Kenapa dia tak touch yang mula-mula tu? The ending you're right. The beginning.
We cannot measure the zero.
Cannot measure because it's a what zero?
at time 0.
At
Time 0.
At time 0. Time 0, nothing happens, right? You still need certain time to pass in order for the concentration to be available in the bloodstream. Because your y-axis is concentration in this plasma, kan?
Yes.
Betul tak? You nak draw the blood. So this graph is plotted against time. When someone, you know, every 5 minutes say taking the blood, for patient kan taking the blood. So at time 0, tak, you know, you baru je bagi administer the drug, right? It's impossible to get any value. So time has to pass, maybe 1 minute to get the peak value, the peak high there. Okay, that's why they never touch 0 in the beginning because a function of time. Kan? Okay. So now jangan mengarut lah ya. Okay.
So for the multi-compartment models, it makes allowance for the uptake of the drug by different tissue within the body and for the different blood flow rates. And the different tissue that share pharmacokinetic properties form the compartments. The convenient labels include vessel-rich and the vessel-poor compartments. And elimination only can occur from the central compartment. First, the two compartment model. In two compartment model, there are central compartment that connect to the second compartment, which are V1 and also V2. And the total volume distribution is the sum of these two compartments. And there are two pathways for drug elimination from the plasma. First is from the central to the peripheral, and the second one from the removal from the central compartment.
So remember the number, what is B1, what is B2, and then bila compartment tu makin expand, you akan dapat number B3, yeah? And then the K just denotes, what is the K?
The rates,
The rates of what?
constants. So the rate constants of
Apa?
the elimination.
Okay, you can, no, not elimination, you can say it's transfer, intercompartmental transfer or intercompartmental movement, yeah? Transfer, sebab nanti the main concept of TIVA nanti you akan jumpa yang BET tu kan. It will reflected in this mathematical model. This is just mathematical models ni. So you boleh kira, kalau tak ada number, you tak ada kira kan. So this is just they imagine and produce it as a mathematical algorithm. Yeah. Okay.
After distribution for the central compartment to the peripheral compartment, it also can be, the drug can be redistributed back to the central compartment. And the mathematical equation for the two compartment model is because two way of the transfer, so got two exponential eliminations, so A and B. So during A, the graph is rapidly decline due to the distributions into the peripheral compartment and also elimination for the central. The B line is the slower decline, is the eliminations from the body and this redistribution from the peripheral to the central. For three compartment models, the body is viewed as central compartment, which is V1, and two peripheral compartment. V2 is the vessel-rich group, and V3 is the vessel-poor group. And distribution into the second compartment is always faster compared to a vessel-poor group. And this is a reasonable model for the majority of the anesthetic agents where drug reach the plasma and distribute to the muscle and fat. And for the three compartment model, the mathematical equation is A plus B plus C. There are three exponential of the eliminations. The red one, the rapid decline is actually the distribution for the central to the peripheral compartment and also the eliminations. And the blue one, the slow decline, because of the redistribution to the distribution back from the second compartment to the central and as well as the elimination. And the green is actually the elimination, intermediate eliminations that occur.
This is very useful to remember.
The redistribution of drug into the central compartment explains why the effect of drug can continue long after its administration has ended. Yeah, that's for compartments. Now we proceed with the TIVA. So TIVA, actually the total intravenous anesthesia refers to the induction and maintenance of the anesthesia using intravenous agent and oxygen on air mix. The anesthesia may be induced and maintained either by an infusions of hypnotic alone or combination with the anesthesia. An ideal drug for induction and maintenance of anesthesia should be predictable plasma concentration. According to a non-pharmacokinetic model, predictable link between the pharmacokinetic and pharmacodynamic effect, no active metabolite, rapid onset, rapid offset, and stable in plastic shrinks. The IV agents may be given by manual infusions or can given by the program machines called as TCI. With the TCI will target the plasma effect or the effect site. And the propofol and remifentanil are the commonest combination of hypnotic and analgesic used in TIVA. So for the propofol, it can be used for both induction and maintenance of the anesthesia, insoluble in water, highly lipid soluble, so risk of accumulation in fatty tissue. A phenol hydroxy group make propofol a weak acid and no active metabolite. The combination of this high lipid soluble and the weak acid make propofol distribute into fat, redistribute back into the plasma relatively slowly. And induction dose of the propofol is extensively bound to the plasma protein, about 98%. Okay, so this is a graph. After the initial bolus of the dose, there's a rapid decline of the plasma concentration. At the same time, there's the effect. So this is a highly perfused tissue, and this one is the poorly perfused tissue. So after the next few minutes, the propofol then distribute the peripheral tissue, and the concentration in the CNS falls. This one, so the patient will be wake up. And distribution half-life is 1 to 2 minutes. And it comes for the rapid fall in plasma level with a short duration of action. And the terminal elimination half-life is 5 to 12 hours, reflecting relatively slow redistribution from the fatty tissue and plays an insignificant role in offset of clinical action following the dose. So time to peak effect of propofol is around 1 to 1.7 minutes. So the brain concentration of propofol is lower than the plasma on induction, but higher during induction phase. So there is a lag time before the equilibrium is reached between the brain and the plasma. The modeling this require monitoring. Usually we use PIS. For the remifentanil, is a fentanyl derivative with pure mu agonist. We have ester linkage, which is rapidly broken down by the plasma esterase. The metabolite have minimal pharmacodynamic activity with increasing age, muscle bulk decrease. This will significantly influence the rate of remifentanil metabolism. The offset is rapid and not really affected by duration of infusions. Therefore, a patient will maybe maintain a remifentanil infusion for the long period without significant drug accumulation. So this advantage for the remifentanil is the analgesic effect wear off so rapidly. So that patient maybe have significant pain post we off the remifentanil. So for manual TIVA, usually use the Bristol model. The Bristol algorithms provide a simple manual infusion scheme. The propofol to achieve target blood concentration about 3 micrograms per ml within 2 minutes to maintain during the surgery. So for the Bristol model, the propofol should be bolus first. 1 mg per kg bolus, and then followed by the maintenance 10 mg per kg for 1 hour, per hour for 10 minutes, 8 mg per kg per hour for 10 minutes, and follow 6 mg per kg per hour for thereafter. So we see here after the bolus, plasma concentration will reduce and the effect will increase, but the effect is sustained and the concentration is sustained after we start the maintenance according to the Bristol model. So for TCI, target control infusion is actually a technique that uses a microprocessor controller infusion pump program with a 3-compartment model of drug pharmacokinetics. It is possible to target either the plasma effect or effect site. So in adult, there are 2 commonly used models with the Marsh model and Snyder model. Which Marsh model is a concentration for the plasma and Snyder is the effect site. So for the pediatric, due to the different kinetics, so the model used is the Fossor. And the remifentanil TCI, the model used is Minto.
Anyone want to add
This
this slide?
actually for this TCI require the patient age, weight, and height.
March model ni memang untuk plasma saja ke? Ada tak effect side? Ada. Dipanggil apa tu? Apa nama dia? Modified March. Yang selalu kita guna dekat neuroanesthesia lah, modified March model for the effect side. And then we'll see why Schneider ada kelebihan dia. Setiap model ni ada kekurangan dan kelebihan dia masing-masing. So we use each advantages to cater to the patient characteristic. Ada patient sesuai guna marsh, ada patient lebih sesuai guna Schneider. Okay. Alright.
So for the plasma site targeting in the graph A, the TCI pump delivers a bolus. This the bolus, the gray graph, and the dose to reach the set plasma target, and then continue the infusions to maintain the target. Once the bolus given, the plasma concentration increase, and the effect we go to the site effect site, and to maintain this steady state target concentration. So infusion was started earlier.
So how to explain that relationship between the plasma concentration and effect site concentration of that line? Explain that relationship. There's a gap,
Because-
right? There's a gap there, kan? With the boluses, with the boluses, you get the plasma immediately sampai dekat CI ke C1 tu?
CT target
CT
concentration.
target, okay, tempat T. Okay. So you see there's a sharp increase, right? That's for the plasma. But if you look at the dotted lines, that is for the effect side, it's dragging on. How to explain that?
The
Kita
drug,
you
the
fikir dulu. Explain that. Then what about effect side?
for the effect side, the TCI pump administer a bolus dose, and then as the plasma concentration increase, and as the plasma concentration fall, and mix with the effects, the machine start infusions of the drug.
Kenapa pattern dia berbeza? Kenapa dia overshoot? The plasma is overshoot. Untuk effect side, right? You see? The plasma concentration overshoot and rapidly decline. But if you compare between the A and B, the dotted line with the effect side, obviously if you related to time kan, hampir separuh kan, dia reach faster, right? So how to explain this?
For the effect side, actually the higher dose is bolus, so that the shorter duration to get the effect.
Okay, so nanti so you're fikir tu, okay, how to explain this, how to understand this, okay. Go to next slide.
So actually the pharmacokinetic model for TCI, as I said, so the population is based on population pharmacokinetic, and the bolus dose equal to the product of the central compartment V1 times the concentrations. Then the amount of infusion into the central compartment to maintain the target concentration is equal to the drug eliminated from the central compartment plus drug distributed to the peripheral compartment, and should be minus that the drug retained to the central compartment.
Tak ayat ni. Tak ayat ni. Faham tak ayat ni? Tak apa, boleh tengok balik. But if you look at our, just now, the graph kan, everything is we're going where? We're going to the central compartment, regardless whatever the models. You always giving into the IV kan, drug, betul tak? So IV is what? IV is going to the B1. It's always a B1. You always top up bolus, whatever, you always giving to the B1. So that's why we're giving our drugs. Okay, so ayat dia beza ialah, so bolus will do the job, yeah, to fill up the central compartment very, very fast to achieve that level where we want to go. So the size of the V1 depends on the model that we use. Sebenarnya between Mark and Schneider, dia berbeza. And not only that, different model juga means that whether you can manipulate or not the V1, which means is it fixed variable or is it fixed value ataupun dia variable values. Variable means you boleh manipulate. Fixed means you tak boleh manipulate. It's calculated by the chip, by the computer. Okay, that's why it's important to use the model. Semua ni you tak payah guna you punya kepala. It's all being calculated by the model. Okay, but this is the very basic. Whatever you give, it will go first to the central compartment. okay, sama ada bolus ke ataupun continuous infusion, the computer microchip akan calculate sendiri how much to give. You just continue saja kan, and basically. So that movement to maintain the target concentration tu, tak kisah target dekat mana kan, okay. So what happen is that there are considerations. How much the computer will give, bukan you yang bagi. How much the computer will give. Yeah, let's say you put that as 4 mic per mil for propofol. Okay, so the propofol will start giving bolus. Lepas tu how much infusion after that will be decided by the computer, bukan you. Unless you guna mass rate yang 10, 8, 6 tu. Which there's a lot of life disadvantages. We talk about that also. Okay, so this is where we need bukan you. The machine will consider how much to give as the infusion rate. So dia akan calculate how much is, calculate bukan measure. Calculate how much is expected drug to be eliminated from the central compartment, that K10 tu. How much is it that the drugs will be distributed to peripheral compartment, which is K1 means from the central, Okay, K12 means from B1 to B2. Very good. K13 means from B1 to B3. Poor vessel, rich vessel, poor vessel. So the machine will think about that. They will calculate that. Okay. And finally, they will also think about, how much the drug will then return back to central compartment, which is from the vessel rate means daripada K21, right? Return back to the central from the peripheral, K, or from the vessel pool group, K31. Sebab asal dia daripada V3. So K31. K tu transfer the fixed what we call that rate transfer, rate constant. Okay. So these are all the elements. So dalam exam, this is what I expect for you to explain. The movement of the drugs. Movement of the drugs. Okay, alright. So understand this concept and then you balik baca for further understanding. Okay, alright.
Right. So target control efficiency advantages is maintain plasma concentration without overshoot and minimize side effect or subtherapeutic. Overuse of propofol is reduced and achieve level anesthesia constant and adequate. For this advantage is population statistic, depends the inter-individual variability and genetic variability. Sorry. Next we go the context sensitive half times. Context sensitive half time is the time taken for the drug concentration to reduce by half once an infusion designed to maintain a constant plasma concentration is stopped. The term contact refers to the duration of drug infusion prior to the stopping, and contact sensitive half time for a specific drug will vary depending on the duration of the infusions.
Semua understand apa yang kita kira, what are we measuring? What are we measuring? Contact sensitive half time.
This is time taken for the concentration of the drug to reduce half after the infusions is being stopped.
Okay. So basically, plasma clearance by 50% after stopping of the, bukan drug clearance, plasma clearance. Plasma clearance by 50% after stopping the infusion. So some drug clear very fast. Some drug clear very slow. Okay. So this is shown in the graph. This is standard graph lah. You ingat lah these 4 drugs. Apa nama tu sampai bila-bila pun kat sini all the fentanyl group, right? Satu drugs campur dengan benzodiazepine, STP, that one, this one. Okay. This one usually more, I mean that one is good to compare only opioids, right? This one is for general anesthetic drugs lah, Okay. Alright, okay.
So
This one's okay. Yang ni fact saja, you all boleh tengok dekat mana-mana pun. Kan?
just want to tell the contact sensitive half time each drug. Depends on the infusions.
Betul. So the context bounded infusion, even propofol pun, okay, there are effects of duration of the infusion. 40 minutes, 4 hours, 8 hours kan. So even for apa nama tu propofol, you can see there's different, and that kalau soalan kedua basically nak tanyalah why. Because of what?
Because the clearance.
Capacity of what? Clearance kan? We're talking about clearance from the plasma. We are talking about how does drug get cleared by apa nama tu?
Metabolism.
From the plasma.
Metabolism.
Metabolism. From the body is elimination. Yeah, from the plasma. Of course, elimination from the central compartment is also, but most of effect of the drug, especially the highly lipid soluble, kan, redistribution, right? That's the main thing, kan? So that redistribution to somewhere is also affecting your plasma concentration. Maksudnya plasma clearance. So plasma clearance dia ada banyak factor dia. You ada hepatic clearance, renal clearance, apa nama tu, non-hepatic clearance. Hepatic clearance biasa kita means by metabolism. Yeah, but metabolism can be hepatic or non-hepatic. Yeah, so some drugs dia boleh bertahan lama, meaning you can give for a long time and then the metabolism is not affected until sometimes. Yeah. So dia ada capacity for metabolism, but many drugs actually have limited capacity. Yeah, enzymes, especially in dependent, yeah. And some drug exhibit behavior daripada first order kepada zero order. Okay, so this all related lah. We baca tu kan, it's related to how the drug is stays in the plasma. How we give, how long does it stay in the plasma? Okay. All right. Then move on next one.
So for the determinants of the context sensitive
Itu dah cakap kan? Okay.
clearance ration. So that's all.
Okay, so this is we answer this later on. Okay. Okay, next question. Ada 2-3 kan you punya soalan. Okay, yang itu tu answer tu semua orang boleh tengok bukan answer. Itu soalan saya sebenarnya. Answer tu dia tak bagilah dalam apa exam masa kita komen tu tak bagilah. Cuma kita bagi guide lah. Okay, this how you should answer about it. This one saya tak ingat ada satu soalan. It's okay. Next, macam okay. This is all the PK kan, and sometimes it's also PD, but pharmacokinetic pharmacokinetic kan, so soalan ni akan lebih berat daripada PK lah. Okay, alright.
Ada last 21.
Last 21. Every year akan ada soalan macam ni. Okay, then I share, macam mana I nak share? Ada dalam email sebenarnya. Sekejap, saya buka. Ni apa ni? Buka je yang ni. Sorry. Saya generasi lama pakai lagi Yahoo Mail. Semua tahu saya punya ni kan. Capital lah pula. Sini. Okay. So, saya explain macam ni. Boleh dengar? Boleh dengar? Okay. Ada laser tak? Do you have a laser?
Laser.
Ni keluarkan. Open in new window. Okay. Tak boleh. Kenapa? Saya nak zoom out. Ada laser tak? Tak ada. Oh, tak apalah ya. Okay, so pharmacology of TCI. Konsep dengan ni. Okay, so next one. Next one is kan. Oh, bukan. Dia PDF. Dia kena scroll. Tak apalah. Okay, so this is okay. What we will be the main principle. First, we talking about the basic PK models, PK concept and model description of TCI, kan? Tak apa, nanti saya share dengan you all, don't worry. Next one, we consider the changes in the PK will affect the pharmacodynamic. That's why kita kata certain patient tak sesuai dengan certain model. Okay, so this will be a pharmacodynamic considerations when you're using TCI. Okay, and then we are also looking at how each model will affect ataupun will require ataupun behave in a different way for dosing regimen for TCI. Yang ni you tak payah buat sendiri. This is what the model will do by itself. Okay, alright. So first of all kita tengok the concept dulu. Okay, so concept dia ialah first of all is calculated, it's not measured. Okay, everyone understand that. Okay, most drug akan will exhibit a multi-compartmental behaviors. Okay, very I don't think there's a drug that is a single compartment. Some drugs do have a two compartment, especially if the drug that is hydrophilic. Okay, they may exhibit two compartments, but majority of the drugs will exhibit multi-compartment, means 3 and more. Okay, all right. The most studied PK models is the 3-compartment models. Okay, using propofol. This is the most studied. That is why we come up with so many models. Not just Marsh and Schneider. There's so many for adult. There's so many, but the more common one is the Marsh and Schneider, because these are the models that's been adopted by the drug company that's made the machine, not because they are more superior or anything. Yeah? Okay, and then the 3 parameters are very important when you're thinking about the PK model. Is 3. These are the 3 important parameters, which is volume of distribution, macam tadi aku malah cakap kan, okay, volume distribution, clearance, and half-life. Because soalan tanya what are the parameters, these are the 3 parameters that the machine will calculate among itself to come up with their own algorithm. Okay, but these are the basis. Okay, the physiological factors, the one that we key in depending on the models. Okay, for example, is age, weight, and some model require to put in gender. Sekali kan? Okay, so age and weight, all models will require that. Some models require you to put gender. Okay, and context sensitive half-time, when we use TCI, it's also actually because some drugs that we use for TCI, right, already has an information about the context sensitive half-time. Remifentanil, propofol, example, right? Yeah. So because of that, we can reliably predict the duration of the drug after we terminate the infusion. How do we use that? Let's say, for example, if we use it for 4 hours, TCI, propofol, and remifentanil, which drug we offer first? Propofol first. Why? Takes longer time to clear from the plasma, right? Compared to the remifentanil. So remifentanil you stop in 3 minutes, dah effect dia dah tuan dah. That's why before stop kita bagi dulu some other form of opioid ataupun analgesia kan, to top up, right? Okay, so that's that. Now 3-compartment model. Okay, I think it's quite cute. Yeah. Okay, so the central compartment is always that V1, right? You see, So from the V1, it can go to the other compartments. So how fast it goes depend on the satu is vasculature. That's why kita kata if it's vessel rate through, then it can very fast go into or preferably or preference to go to that compartment. So what determines the rate? The rate is determined by the transfer to intercompartmental rate constant or rate transfer, which is the Kij tu is just to denote from which compartment to compartment lah. So kalau from V1 to V3, it will be K13. Kalau from the central compartment to the V2, it will be K12. Okay, so just that. And then KEO is the rate constant at the equilibrium. This is the one, the KEO is the one that will determine the how much the machine will give the rate for the maintenance. Okay, so kat mana dia tu? Okay, so imagine at the V1 and the rate is KEO is actually denotes the transfer to the effect side. In our case, effect side is where? The brain, right? So for proper form, kan? Effect side is the brain. So that's why kita split effect side. V2 is vessel rich group other than the effect side. And the V3 is, okay, fat, muscle, the poly, vascular group, right? Okay. So that KEO is actually denote the transfer to the effect side, E for effect. And O is not zero but equilibrium. Yeah. So EO together is at equilibrium. So this rate memang constant lah. So do you think out of this thing, which one yang machine tu akan prioritize? Which rate akan prioritize? Akan prioritize effect side lah. So the KEO will be the main determinant of how much you want to give the rate. The other rate ni, the K12, K13 is the input that the machine will get, right? Will calculate. This semua calculate, okay? That the machine already will calculate in the background. Yeah. Okay. Let's say you nak increase the from 3 to 4. What would happen? What would the machine will do? Dia bagi apa? Very good. So dia akan bagi bonus. Betul tak? But bonus tu depends calculation kat mana? Dia depends lah mode apa you pakai, fikir apa you pakai. If you use only the plasma target plasma, then it will just be a simple. The calculator siap-siap, okay, now we are at 3, if I give this much, it will be the this much that I will I will need to bolus. So it doesn't need to consider KEO. Only K12 dengan K13 dengan K31 dengan K21 je. Sebab dekat plasma je. But if the machine you're using effect side target ataupun apa nama tu the effect side concentration kan, target concentration kan. So then the machine needs to take one extra consideration, which is the rate transfer to the effect side. So the KEO. Okay, all right. So this is the differences in the algorithm. Check the algorithm. Okay, faham yang ni? Faham? Okay. All right. Okay. So how to explain the changes in the 3 compartment model? So alam macam ni selalu keluar. What happen if you give bolus? What happen if you give transmission? Okay. First of all, okay, kalau bolus, still you have to explain about what happened first and what happened at the end. Kan? A single bolus dose means you akan bagi dekat V1 compartment, right? And then from the V1, dia pergi mana? Pergi ke V2 dulu, very good. So that K12, okay. And then V3, K31. But in between that, there will also be transfer from the V2 to V1. So you will also have K21. We don't know how much. That is calculated by the machine. But the transfer is not static. It's not one way. It's 2 ways. Yeah. So if you look at the graph, the first one, the rapid decline to, it's representing what? So that is from the central compartment, yeah? Yeah. So the A, the C dekat A tu kan, E is for the exponential lah, yeah, okay. So A, that rapid decline is from the central compartment, kan, from the V1. Central compartment, what happened there? Why is rapid? Because it's rapidly redistributed. Sebab apa? Sebab dia is very highly lipophilic drug kan, dia buat propofol, right? Okay. And then comes at the second one is the, apa dia? Intercompartmental transfer. This is still the transfer. Transfer where? From V2 balik semula ke V1 and then pergi, then daripada V1 pergi ke V3, daripada apa nama tu V3 balik semula kepada central, lepas tu pergi ke sini, ya. Okay, okay. You hafal ke?
Microscope.
Microscope, serius. Kena intubate?
Very clear.
Okay. Yeah. So this macam mana you explain dalam exam, this how you explain dalam exam. Okay. Itu bolus, right? What about the maintenance? Tu saya cakap. So in maintenance, dia akan menggunakan 3 superimposed infusion. What do you mean by that? Okay. Satu, dia akan bagi at a constant rate to match the K10. Apa K10 tadi?
Elimination.
Elimination from central compartment. Ni bukan transfer ke mana-mana. This is elimination from the central compartment. Could be by metabolism, yeah? Elimination from the kidney. So they ikut gradient, right? They ikut chemical gradient. Okay. So that is number one. So your TCM machine kena match that rate first. Okay. The next one is the phase A dengan phase B tu. What is that? To exponentially decreasing infusion. So apa dia? A dengan B?
Distribution, redistribution.
Yes, the redistribution phase and intercompartmental transfer. That B is the intercompartmental transfer. Okay. The C denotes the ongoing background elimination. Sebab tu dia sangat slow. That one is not even considered in the maintenance part. Okay. But what it considered is the clearance from the central compartment. The K10 tu. Okay, nampak tak? Nampak tak? K10, yeah. Lepas tu, these two, A and B is the intercompartmental transfer. Okay, including the redistribution lah. Redistribution to where? To other compartment kan? Okay, so this is how the maintenance rate is calculated. Okay. Okay, so this one nampak macam difficult je, sebenarnya tak ada pun. Okay. If you look closely, this is comparing two models. Yeah. Marsh dengan Schneider. Okay. So the pink one is Marsh. Pink ke purplish. The purplish one is Marsh. The green one is the Schneider. Okay. Sorry. Apa nama tu? Effect side Marsh dengan plasma side Marsh. Okay. So nampak tak ada beza? Kalau you can nampak ada beza. So yang apa tu plasma side tu you nampak tak dia macam apa tu? Ada dua bukit kan? And if you longer time ada lagi banyak bukit. Whereas the effect side, the green one tu, okay, dia apa tu? Dia lebih landai kan? So this is bolus. To achieve the target by the landai, and then if you want to give another one, this is bolus to achieve the another target. Yang turun tu once sudah stop the infusion lah. So you see what is the difference between infusion rate ni, tinggi ni bolus lah. Bolus. You see or not? So for the plasma, you need high volume of bolus, right? In order to achieve, yeah, to achieve the rate. So second bolus to achieve the rate kan? Nampak tak? Yeah. Nanti you will see also. With the Schneider, kan, slightly different pattern, okay? So what happened is that conventional drug, kita pakai BET tu kan, okay, loading dose and the maintenance rate. Sebenarnya, you nak capai tu, you kena ambil dekat sejam untuk capai, let's say, target of 4 mic per mil. So with the TIVA, it's actually very difficult for us to achieve a proper serum concentration that we want. Sebab tu kalau mesin ni, you cakap dia akan berbagi bolus tu memang nampak besar lah bolus. Kalau you nampak dekat volume tu kan, my god, macam banyak kan. Tapi tu dia calculate sendiri, nampak kat situ memang nampak macam besar, but it's a bit tak besar pun because the machine will already calculate how much that the machine needs. So it's very difficult for us if we use a mass rate. That's why mass rate is not preferred. Sebab kita akan tend either under or over. That very easy. Okay. So even though our TCR algorithm is based on the BET, on the BET, but this is just the base. It doesn't follow exactly like this. Maksudnya, how much bolus that you will give bukan 10 mg per kg. The machine will calculate. Kan kalau BET tadi tu 10, 8, 6, right? That's not how the machine does. The rate, the dose that the machine gives, we don't know. It's the machine punya algorithm. It's a secret. But that's what they do. They will give bolus. They will consider the elimination and the transfer. That's what it means lah when they say based on the back principle. Doesn't mean machine tu buat 10, 8, 6 macam yang mass rate tu. Doesn't mean like that. Okay. Alright. So, mental rate ni saya dah cakap dah tadi. Kan? So, they compensate for what? Elimination from the V1, so the K10, and also the other, transfer from V1 to the V2, V3, and also the other way around. Sebab dia pun tak nak juga overdosing. Kan? Okay. Faham tak setakat ni? Any question? Faham That's the very basic of the PK modeling. Okay. Okay, so this is we're talking about what are the fixed parameters and what are the variable parameters. Why this is important is about certain models. If you look closely, there's only one model where you cannot change the V1. Model apa? That has a fixed V1, which is central compartment. Schneider. Meaning to say, V1 is used mostly for bolus, right? Kan? So, patient on Schneider, kalau patient tu let's say obese ke ataupun patient that muscular, that has a VD yang tinggi, probably you will be underdosing. Whereas patient yang kurus, elderly patient for example, kan, you pakai MASH, you tend to be overdosing. Sebab it has a larger and that V1 even though it is variable, maksudnya dia akan bertukar dengan weight and dengan age, but we tend to also overdosing sedikit. Okay. But the modified Schneider is slightly different. So right now, kalau in Europe, even in obese kita suka pakai modified Schneider. Okay. Sorry, modified MASH. Okay. Baik. Okay, Schneider, let's say in patient who actually for obese patient, there's no model that is fake. We have to know that, okay? There's a new model coming out, but it's not available in the machine. Therefore, for study, for theoretical, okay, but it's not embedded in the machine yang kita guna, from the FK ke, kan? From the B Brown ke, is not embedded in that model, at least what's available in Malaysia. Maybe in the future, they will embed that model for the obese patient. Okay. Alright. Then you have the Pitfuser, Kataria, kan, Minto for the remifentanil. Okay. So you see that the variable parameters, kan, almost all models will have that. Compartment 2 and 3 are variable. Of course lah, sebab you boleh adjust the weight, the age and even the gender, kan. Modified MASH memang ada gender. So you have Schneider, you ada gender. So that how you can, variable mean you can manipulate. Okay. With the exception of the Schneider with the V1, which is central compartment. Okay. Okay. Alright, so this is a bit about the context half times because bila cakap pasal TCI, memang kenapa kita guna TCI? Because we know the behavior of the drug once you stop the infusion. So kalau like exam, kita cakap pasal advantages of using TCI. you should also mention about the knowledge about the context-sensitive lifetime for the drug that we use for TCI. Okay. Apa tu, you can pull up this graph, yeah. Let's say you can see about the, yang ni tak ada, yang ni yang lama punya tak ada remifentanil. The new one ada remifentanil kan. Okay, you can give the propofol and the remifentanil. No need to think about other drugs to show that these two drugs that we use for TCI, this is why we can use the drug for TCI. Because you remember in comparison, kita TCI in comparison to apa? In comparison to apa? TCI versus
Manual
versus TA techniques, TCI versus inhalational. Kelebihan inhalational, you boleh kira ET, end-tidal concentration kan, your MAC, and then once you switch off, you know already, oh within few minutes kita cakap bangun. But with infusion kita tak tahu kan. So kelebihan kita guna TCI is that because the drug that we use, we know about the context-sensitive half-time. That's the use of context-sensitive half-time. To compare against the inhalational, because inhalational we know already. Kan, you stop within few minutes, patient akan bangun. Because we can look at the MAC value from the end-tidal. Kan, end-tidal MAC measurement, right? Yeah. So that to compare with that, so we have the context-sensitive time for the drug that we use for TCI. That's why not all drug you can give via TCI. Kan, infusion biasa, yes, many, but those drugs we do not need to know about the context-sensitive half times, isn't it? So these are the reasons. So bila cakap pasal TCI, bring about the context-sensitive half time. Kalau cakap pasal advantages, apa okay. Alright, I think that's almost okay. So this is the pharmacodynamic consideration. Ada lagi ke? Ni yang draft yang sama, kita explain sikit lagi. Okay, kita buka sendirilah. Okay, effect site targeting. Okay, so sama. This is modified Marsh dengan Schneider, ya. Yeah. So tadi saya kata, nampak tak? Kalau modified Marsh kan, contohnya kita nak target is, kalau plasma is over there, right? So static je kan? So saya tanya tadi, kenapa part ni dia sangat landai? Dia sangat ambil masa. Because effect site is passively follow the plasma concentration. Kita tak buat apa-apa pun. Mesin tu tak ambil kira pun the transfer between the compartmental apa semua, the effect site. It's just passively follow je. Kalau you bagi bonus banyak tu lah dia naik. Yeah. So that is the behavior ataupun profile of the PK used to plasma concentration using the Marsh model. Okay. Schneider pun sama behavior. Tengok tak? Dia bagi bolus kan. Lepas tu tapi bolus volume dia rendah, nampak tak? Compared to Marsh kan, nampak tak? Okay. Dia punya bar, the size of the bar, right? Because B1 dia smaller. Ya, Schneider B1 dia smaller. Okay. So, nampak tak? Dia punya naik tu sangat-sangat slow kan? Because the plasma, the effect site follows passively. Kita tak buat apa-apa pun untuk manipulate. Now, how can we manipulate it so that we can reach here? This is C50 kan? Therapeutic level faster. So that's where. So what we manipulate the size of the bolus. Just tengok tak, nampak tu tak? Nampak tak? The size of the bolus bagi banyak kan? Banyak bar kan? Banyak. Kan? Ni satu dua. Yang tu banyak kan? Tengok tak? So we manipulate the size of the bolus. Okay? So kalau tengok Marsh Schneider sama juga, you manipulate the bolus according to their algorithm. Kan? And then you dapat very quickly can reach the effect site concentration. Okay, yang kat bawah tu continuous infusion lah ya. Okay, then dekat bawah pun sama. You manipulate the boluses, okay, and then quickly it will reach the concentration. Cuma masalahnya ialah kalau Schneider sebab B1 dia kecil, so dia kena bagi banyak volume over time. Kan? Compare tu dengan Marsh. But Marsh memang dia dah besar dah. Okay? So the changes in the bolus tak sebanyak Schneider. Itu beza dia lah. Okay? Okay. Alright. So, tadi balik kepada, okay, pharmacodynamic considerations. Okay, what should we consider in terms of pharmacodynamic when we use TCI? Okay. So macam biasalah kan, it's just assumption. Mathematical calculation. So, there is element of inaccuracy. Contohnya kalau you buat macam ni patient sepsis. Dah berubah dah dia punya fikir dia kan, patient sepsis or obese patient, yeah, or underweight patient, okay, elderly patient, okay. So there's an element of inaccuracy. So when we use that, we always have that in mind. Okay, so you can say this is like disadvantage lah untuk TCI model, okay. And then there will be also inter-individual variability. Tadi aku mau ada pull up satu graph kan, okay. Apa nama tu infusion and then effect keluar kat situ kan. So what's that line yang tengah-tengah tu? Apa tu? What is that? Selalu keluar soalan Viva. What is that? Yang bertembung dengan plasma dengan effect keluar. What is that? What do you call that?
Steady state.
Huh? Bukan steady state, not steady state. What do you call that? C50. That is concentration where 50% of the people exhibit the desired effect. Some people have lower C50. Some people have higher C50. Kan? But majority kan kita buat study, right? Majority at that level, at that concentration, that's when they start to exhibit. Maksudnya kalau this case, they start to loss of consciousness at that concentration. C50, okay. So C50 is variable. Kan? There's inter-individual variability. So memang that's the more challenging lah, unless we can find a truly very good machine that can predict to the nearest mistake, to the nearest standard deviation, that this much not different lah, maybe about 5% je kot, between this. This is the dose that can, knock the patient out. Okay, so that is the C50. Okay, all right. So that is also the disadvantage of TCI. Okay. Plasma concentration is determined with effect site follow passively with time delay. Nanti saya cakap tadi, silakan. Time delay, okay. So saya cakap tadi, kalau kita follow the plasma concentration, you akan ada time delay for the effect site. Okay. With an effect site targeted system, kita boleh manipulate the plasma concentration, the V1 tadi tu. The bolus tu kita boleh manipulate that we can bring the target concentration as rapidly as possible. That what the machine will do. Bukan you kena sakit kepala kira. That's what the machine will do. If you use a target site. Okay. But whatever it is, okay, there is usually a hysteresis. You know hysteresis? Kalau you tengok lung kan? Hysteresis mean dia tak sama lah. A dengan B ni pulang balik yang sama. So you bagi A macam ni, bila balik dia macam ni. Kan? That's hysteresis, okay? When you increase or when you decrease. So, you increase, senang kita tengok effect dia kan? But sometimes daripada let's say 6 kan, BP drop, you pun turun. TCI, right? Daripada 6 tinggi, okay. Daripada 5, you turun jadi 3. Dia bukannya, relationship tu bukan macam straight line, macam you bagi. Yeah? So, kita tak boleh nak predict. Sebab stop kan? Stop means stop medication. Bukannya kita tarik balik ubat yang kita dah bagi. Bukannya mesin tu, tarik balik ubat yang kita dah bagi dekat kopak melainkan. Tak kan, kita just stop saja kan and harap that transfer tu berjalan sendiri. So that's why kita kata increasing the dose and decreasing the dose is not the same. It's not the same, same movement. Dia ada hysteresis. Okay. Alright. So, I think we're going to the last slide. Oh, ada lagi. Okay, effect site targeting. So sama juga I just repeat balik apa yang tu. Okay, rate constant is required, betul. So is required but we do not know. That one. The peak overshoot tadi tengok tak? Memang machine akan overshoot. Sama ada besar atau kecil je, dia akan overshoot. But the actual takat mana yang sepatutnya dia overshoot, we do not. Okay, we do not know. Okay. And okay, the same thing. It is It is a calculation based on mathematical equation that they come with the algorithm. Okay. So this part yang cakap okay, virtual compartment assume to have negligible volume compared with V1 and concentrated changes in the plasma concentration at equilibrium. Okay. So this virtual compartment, okay. So apa yang this virtual compartment ni? Apa maksud dia? This virtual compartment. The effect side. The virtual here means effect side. Sebab kita just virtually kita create je. Kan? Kita denote this at the brain, yes, but it's virtually saja kita create kan. But it is this one is actually at equilibrium kan. We cannot manipulate much because at the end of the day kita akan manipulate the V1. Kan? And the machine will automatically say, okay, now already at equilibrium. So I will adjust this rate by this much. Nampak tak? Sometimes you tengok kan, kalau rasa macam apa, tak perasan kan, you tengok, lepas you dah bagi 4 kan, nanti dia kan auto adjust tau rate mg per minute, mg per kg per hour tu. Ataupun volume tu. You akan sikit-sikit ada adjust sikit. Maybe by 1 mils, 1.5 mils, you nampak ada adjust sikit-sikit. Okay. So that's because you know there's a adjustment, auto adjustment by the machine at the V1, which where we give the drug lah. Kan? Okay. So the rate constant, the KEO is where? Effect side. Okay. Describe equation of effect side concentration with the plasma. So relationship dia between effect side dengan plasma saja. KEO. Bukan tak ada kaitan. It doesn't explain about the V1 to V2 or V1 to V3 or vice versa. Just the plasma dengan effect side sahaja. So KEO. Okay. So that's where the rate constant that that describe this relationship. And where did they get this number? From the EEG study. Because effect side kat mana dekat brain kan kita kata. So kat mana dia dapat this nombor ni, the rate constant tu? From the EEG study lah. From the drug company they buat EEG study. Okay, this is where. So of course everyone is different, right? But that is just the kita kata apa, standard rate constant. Okay. Okay, so this KEO is linked to rate of decay of drug concentration in the V1. Okay, maksudnya apa? Pergi dan mari lah. Pergi dan mari. Pergi dan mari. So drug daripada V1 pergi ke effect side, this akan kurang, betul tak? So the KEO is reflecting how much of the drug concentration in the V1 decaying turun. Kan? To go where? To go to the effect side. Okay. So then this relationship, you perasan, dia KEO ada satu je. Dia tak ada balik semula. Kan? Dia tak ada balik semula sebab drug dah guna. Tak ada balik semula. Okay, so only one direction, right? So this relationship describe how much the drug is being reduced from the V1 to go to the effect side. Okay. Alright. Okay, so kalau KEO dia besar, kan ada rate kan setiap rate dia berbeza kan. So if you have a large KEO numbers, okay, so that means that you will predict more rapid rise in the effect side concentration kan. Maksudnya which one is good? Kalau you nak drug tu fast onset, fast offset, this is what it implies. You nak drug tu faster onset, faster offset, KEO value you nak besar ke nak kecil? Nak besar, very good. Why? Because large KEO numbers means that it is rapidly increased in the concentration at effect site, which is the onset kan? And also rapid decline in the effect site concentration during recovery. Maksudnya offset. Okay, so large KEO is good. Okay, alright. So different different models ada slightly different. Certainly between the drug there's a different numbers kan. But different model pun ada slightly different numbers lah. Okay, so we always prefer our KEO to be larger for faster onset, faster offset. Okay. Okay. Siapa yang ada OT sila pergi ya? Ni semua tak ada kerja ke? Lepas tu petang?
Ada partner.
Oh, ada partner. Okay. Alright. Okay. So sedikit model dosing regimen. Okay, dosing regimen. Okay. Maksudnya different models effective on dosing regimen. Okay. Alright. So for both Marsh and Schneider, okay, the bolus dose, okay, of propofol used in the effect site target model kan. Okay. Apa nama tu if you compare to the plasma target. Kalau you compare dengan plasma target, dua model ni memang akan bagi large volume. But kalau you compare between these two model, Marsh akan bagi a larger bolus compared to Schneider. Okay. Alright. Okay, so Marsh always administer a larger bolus in either mode due to significant difference in the V1 calculation lah tadi. Okay. Lepas tu, Minto model for remifentanil can be used in the effect site target, okay, but the KEO use is derived from studies of EEG. Sedangkan remifentanil itu energetic. Betul tak? So, you boleh pakai effect site, boleh, kan? But it doesn't really reflect the effect site. Sebab the KO yang dikalkulate tu macam propofol, dia guna EEG model, which is tak berapa tepat lah kan? How you use EEG to measure pain? Betul tak? Kan? So, kalau kita bagi, that's why sometimes kita perasan tak, remifentanil kita pakai tu sebenarnya it's higher dose of it's higher than the dose required for the anesthesia. Lepas tu pasal you bagi, pasal you sidik je. Nampak tak? You can always offset your propofol by as much as 40% kalau you pakai remifentanil. Because the dose that we use is actually sedative dose lah. Yeah. Which require larger dose compared to the analgesic dose. Kan? Okay. So that is one of the caveat of using a Minto model when we want to do a effect site. Okay. Alright. And then for rapid onset of effect, okay, drug with a large KEO, okay, should be chosen. Apa lah, kita cakap tadi kan, same thing, right? Okay, for example, rapid induction, alpha-thalamic may be the opioid of choice because the peak opioid coincide with endotracheal intubation. Oh, itu soalan boleh tanya survivor. Kenapa you guna remifentanil ataupun alfentanil compared to the fentanyl? Boleh fentanyl, that's why kita pakai 2-3 minit dulu sebelum. In fact, kita bagi fentanyl, lepas tu bagi propofol, that's one minute. Lepas tu bagi masa relaxant, 2-3 minutes more, right? That's about 5 minutes, right? Baru kita intubate kan. Because that's how much you need the peak level of the fentanyl. But kalau you pakai remifentanil, sekejap je. Kan? So, this is the explanation. Kenapa bila kita pakai remifentanil, the effect is quick to coincide. So, it's preferable, okay? Because of the large KEO. Again, explain tadi. Fast onset, fast offset. Okay, very good. Okay. Alright, so for a slower induction in which non-depressant muscle blockade is used, it may be appropriate to choose fentanyl with slower onset to coincide with the peak. Sama macam tadi kan, okay? So kalau you memang akan guna masa relaxer, you ada masa lagi yang boleh wait at least 5 minit kan? Silakanlah, boleh guna macam fentanyl. So fentanyl saya tak pernah guna. Siapa pernah guna fentanyl? Ada ke kat Malaysia? Dekat KKM ada ke? Dia tak ada. Alfentanil dulu kita ada dan kita pernah guna dekat dekat neuro ICU infusion sebelum kewujudan remifentanil. Masrate lah tapi kita ada pakai alfentanil. But now alfentanil pun dah tak ada dah dekat pasaran. Okay. Alright. So faham the apa nama tu, this one, this number ni, the KEO. Okay, that's it lah. Boleh baca seterusnya, Millers. Ya, kalau nak apa nama tu, apa brain berkembang lagi, bolehlah baca Millers. Tapi kena baca 3, 4, 5 kali baru faham. Tak apalah, saya first year pun saya tak baca pun Miller. Miller ni lepas kita nak apa, in-depth knowledge lebih sikit. Lepas kita dah pass exam kan, kita happy kan pass exam kan. Lepas tu baca Miller. Okay. Okay lah it's okay. Baca Miller awal-awal ni, apa nama tu, it's good. Kalau you dah ada basic concept, it's good for your understanding. Cuma saya tak kata you wajib baca Miller to understand this. You baca sloting pun ada dah. Okay? Sloting pun ada dah. Okay. And this is just the the PGA education. If you can get access to, dulu it's free. If you can get access to, it's a very good revision. Revision notes, certain key concept. It's very good revision notes. Okay. Alright. Okay, any question? Kita faham sangat dah. Tak ada soalan langsung. Dah faham sangat. Okay. Very good. Kalau dah faham sangat, very good. Okay. Ini just natural law saja. So I mean, you all basic mathematics ni kan, ni basic mathematics je ni. Basic law. Natural law. Natural law. Natural law. Law. Natural log. So tak ada apa sangat. Tak payah pun for mathematics. Just come up with this, you know. Apa nama tu, shape of the graph, you be able to explain, remember the equation and remember what it means kan. Alpha, beta, gamma. Apa dia? Ya. Yang ikut BET tu ke?
Yang macam terbagi diffusion. Kalau ikut dah agak tinggi.
Memang agak tinggi, and also belum tentu lagi pun apa nama tu patient ni. So the best would be adalah something BIS monitoring ke. At least you can guide the use with that. That is better lah kalau you pakai even TCI pun. Tapi TCI ni kalau tak ada pun at least kita comfort sikit lah kan. Oh no, if bagi 4 memang 4 lah patient akan dapat kan. Say format per mil, memang format per mil lah patient akan dapat kan. So with apa nama tu, with the mass rate kan, mass rate, then memang you akan either under ataupun over. Most of the time over lah kan. So it's good then you have BIS, then you can use BIS as a monitoring. Kalau terpaksa kan. Tapi kaya lah pula ada BIS monitoring, tak ada TCI ya. Sebab TCI tu tak bukan pakai buang kan. BIS tu pakai buang. Macam apa, berebut. Okey lah, mungkin berebut pun kan. Betul. So that is, sekarang ni kita cakap TIVA. So TIVA is an umbrella, is a big like umbrella kan. So TIVA, saya kata, bukan TIVA/TCI. It's a TIVA by TCI. Or TIVA by mass rate. So kalau boleh kita tak nak lah TIVA by mass rate. Maybe let's say pediatric patient datang for AV kan, tak ada model yang boleh buat 6 bulan kan. Itu paksalah pakai. Paksalah. So but that is the disadvantages lah, that you do not know what is the real requirement of the dosing. So kalau kita follow that one, 10, 8 mg ni, tak ya, baby 6 bulan. Kita nak maintain spontaneous, let's say rigid bronch ke kan. So that remain a challenge. So kalau boleh kita ada BIS monitoring, kita monitor dengan BIS. Otherwise memang kita based on clinical ni lah, and then macam tu lah, kalau anda nanti dapat spasm pula. Susah. I mean that's the challenge. That's the challenge. Dengan mass rate. Kalau TCI at least you can get somewhat. So most of us kita pakai je TCI machine even for 6 months. Try pakai the let's say the diffuser kan. Buat lah let's say 3 tahun. Kalau tak machine tak gerak kan, buat dalam 3 tahun and then you just because we do not know at 6 months for inhalational, that's the peak concentration, right? That's the highest requirement, right? At 6 months, and then they decline. And then follow the similar to adult, right? At about 2 years, kan? But for the propofol, kita tak tahu. Is 6 months is the highest requirement? Kita tak tahu. Kita tahu with inhalation dah. Kan? Kita tak tahu. So, kalau saya suka pakai, this out of topic lah. Kalau airway, saya suka pakai ketofol. Ketamin plus propofol. Sebab in any case, you pakai mask rate kan. Kita adalah, kita punya apa tu, regime. Okay. But since we're gonna give glyco anyway for the airway manipulation, so ketamin tu very low je sebab you pakai either 1:3 or 1:4 ratio. But that ketamin will offset the effect of propofol. Kalau terus salah bagi lebih sikit, kan? Can counter the effect of the propofol. So tak adalah patient ready. Kan? While you insufflate dengan side port kan? Wrong kan? Kita buat rigid, sorry not wrong. Rigid bronchoscopy pediatric kan? So that's really my technique of choice. And usually, nama tu less incidence of, spasm. So, but then again, in pediatric, ada its own model. So some of this question can come out about specific population. Okay, contohnya TCI in pediatric, TCI in elderly, TCI in obese. Apa consideration? Soalan dia akan tanya, apa changes? Apa changes in the body component, right? And then how does, using 3 compartment model, how does it change? How does the compartment model change in this population? So become unpredictable kan, one compartment is more than the other, there's more fat compartment kan. So kita tak tahu how much is going there. The rate constant now has changed. So that part is the consideration. Yeah? So kalau soalan keluar pun biasa kata macam tu lah. So you talk about effect changes in the pharmacokinetic as well as pharmacodynamic. Kalau soalan tanya pasal pharmacology. Soalan tanya just fikir saja, fokus kat fikir. Baca soalan dia. Okay, alright. So if there's no more, saya stop kat sini ya. Tak apa, nanti saya hantar dekat WhatsApp lah senang. Saya boleh hantar dekat Akmal, nanti Akmal boleh share dalam grup ya. Okay. Okay. Mana pula ni? So, tak larat nak berjalan. Oh, Viana. Ni one way je ni. RM900 tu belum masuk lagi dengan benda-benda lain apa semua. Book by 13 Julai.
Thank you, Doktor.
Ya, sama-sama. Thank you Akmal. Okay.
Mic ni bagi siapa? Pak Iska.
Thank you, Dr. Laila.
Kita lagi nak pergi China. Aduh. Dan dia pada pandang.
Oh.
So dia kan sejuk lah pula. Kata-kata. Dah tak keluar dari kanan. It's very cool lah mountain.